بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. Good news, I found my microphone. So الحين نقدر نرجع أخيرا ونشرح درس الأزمة في محاضرة Family Medicine. بعض السلايدز موجودة من تفريغ تالا على مدركة، يعطيها العافية، مرة حلو. إذا عندكم وقت أنصحكم تمرون عليه. Okay. So our objectives: define bronchial asthma, recognize the clinical presentation of asthma, know the principles of asthma assessment, know the commonly used medications in asthma, and this is the most important, honestly, understand bronchial asthma management and the management of acute asthma attacks, and no indication of referral to asthma specialist. So asthma is the most common chronic disease in Saudi Arabia. Prevalence is 14.3%. It has significant impact on patients, their families, everything, hospital. Okay. And it's very underdiagnosed and undertreated. So what is asthma? مراجعة سريعة. It's a history of respiratory symptoms, which include wheezing, shortness of breath, chest tightness, and cough, and which varies over time and in intensity. So we know that it's exacerbated at night and often with variable expiratory airflow limitation. So asthma is a chronic inflammatory airway hyperresponsiveness disease that results in airway narrowing. This is caused by either increased mucus secretion or bronchial wall thickening. So the bronchial wall thickening is either caused by the edema from the inflammation, the smooth muscle hypertrophy, or the subepithelial fibrosis or airway remodeling, which occurs if the disease is persistent. And asthma may be allergic or non-allergic. Allergic like in hypersensitivity, حساسيات, non-allergic زي مثلا في الجرد. Oh, there it is. The diagnosis of asthma is based on clinical assessment by a detailed history, a physical examination, and an investigation, which is the spirometry with reversibility testing. So the combination of wheezing, cough, shortness of breath, and chest tightness are not specific of asthma, but when you see them together, they increase the probability that, this probably is asthma. The pattern of symptoms is usually varying over time, and the patient may be entirely asymptomatic between attacks. هذه أشياء كلنا نعرفها من قبل. Again, asthma can be provoked by exercise or other triggering factors such as viral infections or smoke. Asthma and rhinosinusitis commonly exist. عشان كذا مهم في الهيستوري نسأل عنهم. الرhinosinusitis إيش الفيزيكال ساينز ممكن نشوفها؟ نشوف mucosal swelling, نشوف nasal polyps, or also post-nasal drip. Asthma diagnosis can be supported by taking detailed history, including patient's occupation, family history of asthma, and other allergic disorders, and smoking. Occupation يشمل فيه الشغل نفسه و also pets. لا تنسون تسألون إذا عندهم pets at home. Asthma control may be worsened by coexisting conditions, زي إيش؟ GERD, rhinosinusitis, obesity, sleep disorders like OSA, and the use of some medications زي إيش؟ beta blockers. هذه نقطة مهمة ممكن يجي عليها سؤال. NSAIDs and aspirin. This is because leukotrienes, which increase when we use NSAIDs and aspirin, may trigger asthma symptoms. Relevant questions: the diagnosis of bronchial asthma, family history, allergies, wheezing, cough, symptoms after exercise, زي إيش الsymptoms? Wheezing or coughing, occupation, pets. medication history الميديكيشن ذكرناها اسألوها بنفسها aspirin, NSAIDs, beta blockers. Previous diagnosis or treatment of asthma and exacerbation of symptoms under any special conditions مثلا في غبار برا موسم انفلونزا سويت رياضة هي. Exposure to environmental smoke, cigarettes, burning, بخور أو حرق أي خشب أو فحم. Okay. Does the patient's cold go to the chest؟ زي مثلا المريض بيقول إنه البرد نزل على صدره or take more than 10 days to clear up. هذا also may indicate asthma. And are symptoms improved by appropriate asthma treatment؟ هذه يعني in general لو قال مريض أيوة أنا عندي history of asthma نسأل نسأل تفاصيل متى كيف كان was it controlled إيش الأدوية اللي كنت تأخذها هل كانت تفيدك أشياء مهمة نعرفها يعني be curious. Are there any features suggestive of occupational asthma؟ إيش هنا مكتوب أي هذه الساينز إذا تحبون تقرونها. طيب physical exam It is important to note that the examination of the chest may be normal and stable and controlled asthma, but the presence of bilateral, expiratory, widespread, high-pitched wheezes is characteristic of asthma. كذا بالأخير كذا في wheeze. طبعا I don't have asthma right now, but you get it. This may be accompanied by shortness of breath, diminished oxygen saturation, and it's important to examine the upper airways, not just the lung bases, to look for evidence of allergic rhinitis. زي إيش قلناها mucosal swelling, nasal polyps, and postnasal dripping. What investigations إيش عندنا؟ قلنا spirometry, which is a type of pulmonary function test. It's necessary to confirm airflow obstruction and demonstrate significant reversibility. إيش قصدنا الreversibility؟ إنه إحنا أول شي بنقيسه بالسبيرومتري بعدين نعطيه bronchodilator يستنى ربع ساعة أو أكثر بعدين يرجع. أوكي يلا الحين بعد البرونكودايليتر عيد الاختبار فاد معك خلاص عندك أزمة ما فاد معك عندك شيء ثاني which is COPD بس ما ندخل فيه الحين. So when do we say it's significant reversibility? If the FEV1 is more than 12% of the previous reading. يعني في 200 milliliters from the 200 milliliters لو كان يعني ال volume of air. طيب performance assessment of asthma control. We also have شيء اسمه ال peak expiratory flow rate. It assesses airflow limitations and post bronchodilator reversibility. طيب هذا هو نفسه في السبيرومتري. يعني إيش بالضبط نقيس؟ إحنا نقيس ال FEV1 بحقنا ال respiratory loop اللي كان فيه ال inspiratory و expiratory وبعد نقيس ال peak expiratory flow rate اللي كذا بيكون شكله ولا أتوقع كذا موجود تحته. طيب document any current treatments و side treatment related issues side effects adherence inhaler technique هذا إذا كان عنده history. We're going to utilize a written asthma action plan. بعد ما خلصنا ال investigation طلع والله أيوة عندك asthma نسوي ال action plan. ومهم بعد لما نسوي ال action plan نحط في بعين الاعتبار any comorbidities زي اللي قلناها قبل rhinosinusitis, GERD, obesity, OSA, psychiatric conditions, anxiety زي في panic disorder, exercise induced laryngeal obstruction. وطبعا close monitoring. So هذا هو ال peak expiratory flow rate يعطي العافية تعالى ضافته. So it basically measures your best ومن الاسم expiratory flow based on the person's age, height, and gender. طيب مثلا في هذا المثال healthy patient with no asthma, the reading is 630. طيب لما نحط 630 نشوفه ايوه حطيناه it's in the normal range for people with this height. It falls within the predicted normal range of a male of this age and height. Okay, good. What about مثلا in the case ثاني هنا a female, her best was 620. Wait, personal best 620 ايوه. Current reading is 380. So نشوف 380 اوكي لا نازل خلاص بس هذا. طيب خلصنا تكلمنا احنا عن ال initial assessment of a patient. طيب how do we say that the patient has controlled asthma or uncontrolled asthma؟ هنا عندنا شيء اسمه the asthma control test, the ACT. ACT شيء مهم في عندنا. It's basically a questionnaire, several questions that asks about these things. So symptoms and use of rapid onset beta 2 agonist symptom relief. يعني هل عنده symptoms يحتاج يستخدم SABA for it. هل عنده nighttime awakenings. Does it affect their daily activities? How much is their FEV1. وبعدين نشوف السكور. attacks that require oral steroids or hospitalization. oral steroids نحتاجها إذا كان شيء severe. طيب based on this إذا كان controlled الsymptoms يا ما تجي أو تجي less than twice a week. nighttime awakenings يا إما ما يصحى أو once a month. Effect on daily activities none. FEV1 more than 80%. Asthma control test equal to or above 20. Zero hospitalizations. طيب partial control يجي هنا نقول less than twice هنا more than twice. 2 or more attacks a month, some limitations. Will FEV1 60 to 80% of the predicted value. Asthma control test is 16 to 19. And 1 attack per year that requires hospitalization. وحتى إذا مثلا someone on their first presentation أول مرة يعرف إنه asthma وعرف by being hospitalized فإحنا نقول إن عنده نقدر نشخص ونقول إنه هو partial control asthma. ما نحتاج يعني multiple attacks وهذا نشوف more than twice a week or a month عادي. طيب what about uncontrolled? So symptoms throughout the day يعني دائم عنده. They have 2 or more attacks a week. The effect on daily activities, it causes extreme limitation. ممكن يكون زي wheezing after exercise. FEV1 is less than 60%. Asthma control test less than 16. Attacks that require hospitalization 2 or more per year. هذا الاسم control test ما هو مرة مهم بس you just need to know that it exists. طيب قاعدة دائما whenever we treat anything we want to use the minimal effective dose. It applies also to asthma. والحين كل المانجمنت حقنا بيعتمد على this level of control. إذا هو controlled with an ACT of 20 or more, partially controlled of an ACT of 16 to 19, uncontrolled of an ACT of less than 16. طيب what do we do when control is not achieved? يلا think a little. إيش ممكن يكون السبب؟ ممكن يكون مشكلة في الدواء نفسه يحتاج تغيير أو مثلا الدوس ما يكفي. ممكن المريض ما هو ملتزم بالعلاج أو ممكن هو أصلا يسوي بالطريقة الخطأ فيصير البخار قاعد يسرب الباودر ما قاعد يدخل كامل. Maybe the patient needed a spacer or they need a different device. Maybe في obstacles ثانية يخليه ما يستخدم الدواء والله غالي فيقعد يحاول يوفر عليه. They have concerns إنهم مثل ما يثقون فيه، أو they don't think they believe إنهم يحتاجون لهالدرجة. وطبعا ممكن ال environment حقهم ما يسمح لهم إنهم يكونون يعني well controlled. طيب هذه أشياء الحين assessment of risk factors for future asthma attacks. هذه أشياء لازم نعلم المريض عنها، إنه ترى ممكن يجيك، ممكن يصير. you need to keep them in mind. نعلم المريض، وفي نفس الوقت we put in mind إذا شفنا هذا الشيء نقول له ترى في احتمال. طيب إذا كان يستخدم ال relievers كثير makes sense، يعني to rely on them. إذا احتاج يستخدم inhaled corticosteroids, they have a low FEV1, they had a previous ICU admission, they had a severe attack in the previous year, major psychological disorder or reduced socioeconomic status، ممكن تكون تسببهم stress، ممكن تسبب psychiatric disorder زي ال comorbid anxiety or panic disorder. Continuous exposure to allergens, pets, dust, presence of comorbidities اللي ذكرناها قبل، active smoking and vaping, frequent use of oral steroids, and persistently elevated sputum or blood eosinophilia. باختصار eosinophilia، دائما عنده eosinophilia، دائما عنده حساسية. لسه باقي. طيب bronchial asthma management هو chronic disease. هو chronic disease characterized by attacks. فإيش نحتاج؟ نحتاج إذا جاء الأتاك we stop it، وإذا راح الأتاك we try to manage. We have a long-term goal of asthma therapy to achieve and maintain asthma control by utilizing pharmacological and non-pharmacological measures. Appropriate implementation of non-pharmacological measures is expected to lead to utilization of the least possible dose of medication to minimize the risk of their side effects, if any. زي أي مرض ثاني. طيب our long-term goals في زي flowchart هنا. We want to control the symptoms. We want to use reliever therapy as minimal as possible. We want to use them less than 2 days a week. 2 days a week or less than that. Maintain a near normal pulmonary function. Maintain normal exercise and physical activity levels. Prevent recurrence of symptoms like asthma flare-ups. Minimize the need for ER visits or hospitalizations. هذا شيء بسيط، ممكن يكون بس عن طريق نقول المريض إنه يلبس كمامة لو يعني في allergens. Optimize asthma control with a minimal dose of medication, reduce mortality in general, optimize quality of life, and reduce risk factors. Developing a partnership with patient عشان تعرفون هذا family medicine. Asthma education, and identify and reduce exposure to risk factors. طيب. Asthma education is very important، وهذا دور طبيب الأسرة أو حتى any physician، يعني هذا مهم لحياة المريض. طيب. Our goals here are developing partnership and common goals, sharing understanding, addressing relevant concerns and expectations, and continuity and consistency providing education. هذا عشان تتذكرون الكراب رايوب لما تجاوبون في الآسك لازم تغطونهم كلهم، وهذا من ضمنهم. The outcome اللي نتوقع من education, the patient understands the asthma risk factors by explaining it simply, acknowledging the role of prevention, environmental control, and importance in avoiding triggers, because the first line therapy is avoidance. Recognize difference between controller and reliever treatment, address adverse events of medications, explain devices and the importance of compliance with treatment, recognize worsening asthma and explain the action plan, define comorbid conditions, and provide recommendations. I'm not going through this خاص. You can see them yourself. هذا ممكن بس بالنسبة للسعودي Initiative for Asthma سينا they recommend متى follow up على حسب asthma control. إذا كان well controlled ف regular follow up every 3 to 4 months. وإذا لاحظنا إنه was controlled by هذه 3 months we can consider stepping down, which will explain what stepping down means. But in general the treatment of asthma has a step up step down approach اللي يغضنها من سنة رابعة. We have partially controlled ACT is 16 to 19. So this would be إذا هو كذا we recommend modifying treatment or then following up within 1 month. If it's uncontrolled, less than 16, so we'll increase we'll increase the reliever, we'll increase the ICS level. We'll explain all these كلهم زيادة بعدين. وإذا كان symptoms persist and rapidly increasing, we need to seek medical help from the pulmonologist or transfer patient to the ER. You can also read these. So, ملخص بسيط. Assessment of asthma patient. First, history and examination. We go vital signs. Look for shortness of breath, signs of allergic rhinitis. We auscultate bilateral expiratory wheezes. Then, we're going to do investigations. A pulmonary function test, spirometry. Normally, FEV1 is more than 80. لكن هنا عندنا بيكون less. So based on that, we'll see the severity. If it's if it's 80 or less. If أنا قلت less ولا more هنا. Normally it's more than 80. Then if it's 80 to 60 partially, and then if it's if it's less than 60, it's severe. And then we're going to compare the peak expiratory flow rate. After that, we have a management plan. We're going to document if the patient's currently on any treatment, assess for comorbidities, and write the action plan. Action plan is based on the patient's level of control. If ACT is 20 or more, we go for step 1. ACT is 16 to 19, we go for step 2. And ACT less than 16, we go for step 3. هذه الأشياء بنغطيها soon برجع لها بعدين. وأهم شيء بعد ما we write our action plan, number 4, we optimize the patient education. طيب. The pharmacological management of asthma is composed of both reliever and controller. دائما we need to make sure that the patient has both medications. Any asthma patient needs to have both. طيب. What is a reliever? It is a short-acting bronchodilator agent, SABA, such as salbutamol, that is recommended to be taken as needed basis to relieve symptoms. أول ما يجي الأتاك ناخذه. طيب مو بس SABA، في شيء ثاني اللي هو inhaled corticosteroids and formoterol, which is a LABA. هذا combination is used as both reliever and maintenance. So هذا good. هذا كذا يصير نعطي المريض يعني دواء واحد بدل دوايين. So it's also used as a reliever therapy as needed basis. Okay. Controller medication mainly وعادة يكون inhaled corticosteroid. It's the most effective controller and the cornerstone of asthma treatment. If the patient is uncontrolled, we may need to add another controller medication. عند الشيء اللي هو leukotriene receptor antagonists اللي هي ال LTRA. زي إيش؟ لو تتذكرون في سنة ثالثة زافرلوكاست ومونتيلوكاست، هذا اللي قلنا نستخدمها for pediatrics أو specific يعني in children. أهم شيء إنه during use of control medication لازم يكون في reliever or rescue medication during all the steps دائما just in case. حتى لو كان هو well maintained وماشي زين لازم يكون عنده هذا. وزي ما قلنا قبل, increasing the use of reliever treatment is usually an early sign of worsening of asthma control. Okay. Pharmacological management. ICS is recommended for all steps. It's the most effective. Uncontrolled patients on ICS may require addition of other controllers زي إيش؟ either LABA اللي هو الفورمودرول most commonly, أو ممكن a long-acting antimuscarinic agent لو ما كان tolerating اللابا, أو leukotriene receptor antagonist إذا كان هو من pediatrics أو also not tolerating اللي قبل. طيب, the combination of ICS and formoterol in a single inhaler is recommended to be used for regular maintenance dosing and when needed as well. So هذا قلنا إنه هو 2-in-1. This 2-in-1 thing is called maintenance and reliever therapy marked. طيب, once a day fixed dose combination of ICS and LABA is currently available that can be prescribed with SABA. So ممكن مو شرط إنه يكون بس ICS ولابا لحالهم, نقدر نستخدم هذا كمينتنس لحاله ونعطي SABA just in case as a reliever therapy. إيه, هذا نفسي مكتوب قبل quite literally. طيب, بس when compared with SABA alone as a reliever, fixed dose combination of ICS and SABA lead to better outcomes with significant reduction in asthma exacerbations, hospitalizations, and asthma-related death. Glaze. طيب, أهم شيء نسوي regular assessment of adequacy of treatment, proper technique, and adherence. Regular assessment for independent risk factors for acute asthma exacerbation in the past 12 months or prior history of admission to an ICU, especially if intubated. لازم نعرف risk factors in general لما نعطي medication. Other modifiable risk factors are recommended to be addressed, such as pregnancy, inadequate ICS use, smoking, vaping, comorbidities, and major psychological conditions. دائما لازم risk factors. Regular assessment of risk factors for fixed airway obstruction that includes inadequate ICS treatment, exposure to tobacco or smoke, and nauseous substances, low initial FEV1, peripheral blood eosinophilia. خلاص نعرف هذه. أهم شيء we manage these comorbidities and especially rhinosinusitis لأنه هو like إذا كان موجود highly indicates إنه في asthma. Treatment includes nasal saline washes, nasal steroids, leukotriene receptor antagonists, and antihistamines. So it's recommended that we treat this rhinosinusitis. Nasal saline washes, nasal steroids, leukotriene receptor antagonists, and antihistamines. Okay. For reliever therapy, في بعض the points that should be considered. Oral bronchodilator therapy should not be prescribed due to slower onset of action and higher side effects. طيب, مو إحنا البخاخ هذا نحطه في فمنا? We do, but no, this isn't oral. Oral نقصد شيء كذا ينبلع. هذا is a metered dose inhaler. So it's inhalant, استنشاق. LABA should not be used alone as maintenance monotherapy in children, and it should only be used in combination with ICS. Concepts for controller therapy. Controller therapy is used regularly most likely daily, to keep asthma under control and prevents future risk of adverse outcomes. We need these following considerations. ICS, the most effective. Oh my God, خلاص فهمنا. It's the most effective first-line maintenance monotherapy for childhood asthma. Okay. For significant local side effects, enforce the use of a metered dose inhaler, MDI, with spacer. هذا إذا كان عندنا لو قلنا صار عندنا local side effects نقول نستخدم spacer. Consider a change in therapy, reduction in dose, or frequency of ICS. Advice for a vigorous mouth washing after inhalation, and use of appropriate local antifungal therapy for severe oral thrush. هذه السايد افكتس اللي نعرفها من قبل. طيب متى نحتاج نسوي هذا الكومبينيشن؟ إذا إحنا سوينا الأسسمنت وقلنا والله هذا ال ACT حقه less than 16، يعني نحتاج step 3 هنا لما ندخل في step 3. وهو صدق actually يجي بعد في step 2 بس يعني lower dose. طيب ليش قلنا formoterol؟ ما قلنا بس ICS LABA؟ لأن formoterol هو fast acting component، فعشان كذا هو يصلح للمينتنس والريليفر ثيرابي مارت. وهذا is the treatment قلنا يناسب للchildren بشرط يكونون 5 سنوات أو أكبر، والأدولتس اللي أقل من 5 سنوات بتكلم عنهم بعدين. For children over 5 years, more approaches recommended as maintenance. Maintenance قلنا معناته daily، فكم 1 or 2 puffs once to twice daily. البافس هي أصلا نحتاجها لما هو يحس بتحسن، يعني أول واحدة ما فادت عادي ياخذ ثانية، بس لا ياخذ أكثر من كذا خاص، اللي يحتاج زيادة ياخذها في وقت ثاني في اليوم. And as needed for symptoms, 1 or 2 puffs نفس الشيء، وهذا للريليف every 4 to 6 hours. ما فاد معاه استنى شوية جرب بعد 4 أو 6 ساعات. The maximum number of puffs per day is, to put this in yellow, is 8. أهم شي هذا max puffs 8. لا ما حد يتعداها. ممكن actually تخيلون 8. It kind of looks like a kid. 8. Oh, زي snowman. The MART approach was demonstrated to be associated with lower risk of acute exacerbation and more cost effective. Okay, finally. So there's insufficient data to recommend short courses of high dose ICS in children with mild intermittent asthma attacks. احنا قلنا انه بتشوفون بعدين عندنا شيء. خلينا نطلع من هنا. اوكي هذه الستبس. الستبس in general of treatment هذه هي. لما نقول step 1 نقصد انه we use ICS and formoterol as needed. As needed يعني only reliever. Step 2 low dose ICS and LABA, low, then medium dose. Step 3. Step 4 high dose. ممكن we add LAMA الانتي-muscarinic. 5 we consider switching to biologics or referral to specialist care. فهم قصدهم هنا إنه in children there's low evidence of the efficacy of high dose step 4. يعني بس نركز على هذا first 3 steps. Children with frequent or severe asthma attacks are recommended to receive regular treatment with ICS. Chronic use of ICS for more than 3 months in pubertal pre-pubertal age children can suppress growth velocity, which is dose dependent. يعني في طفل عنده أزمة أو ياخذ ICS، قالوا أهله أوه نو لاحظ يعني كأنه متأخر في النمو مقارنة بأخوانه ومقارنة بالناس اللي بعمره ومقارنة كذا. yes puberty أيوة بشوي بيتأخر في الطول، لكن asthmatic children when treated with low dose inhaled corticosteroids attain normal adult height but at a later age. وتأخر بس مو معناته إنه خلاص بيبقى يصير لا، بعدين فجأة بيطول، يعني it's all good. So بس هذا إذا في أحد من الأهل كان عنده concern you should know this. طيب children commenced on leukotriene receptor antagonists should be followed during the early phase of initiation for development of neuropsychiatric adverse drug reactions. هذا the most common side effect حقهم: anxiety, irritability, aggressiveness, sleep disturbances. وإذا صار عندهم هذا neuropsychiatric adverse drug reaction, just stop therapy. Stop. This is a nice مكان للسؤال. طيب هذا ملخص إيش هو المارت approach. For children that are 5 or older, MART is low-dose inhaled corticosteroid and formoterol. We use it for maintenance and acute exacerbations, 1 to 2 puffs 1 to 2 times daily for maintenance, and for acute 1 to 2 puffs every 4 to 6 hours, and max is 8 puffs a day. The benefit of the MART approach: it has a lower risk of acute exacerbations and it is cost-effective. What if we want to step up? زي ما قلنا هنا, we want to step up and go to step 4. There's insufficient evidence to recommend that, so don't do that. Instead, children must be on a daily low dose of inhaled corticosteroids for management, especially if the asthma is frequent and attacks are severe. Leukotriene receptor antagonists may be added in children with rhinitis, viral-induced wheeze, exercise-induced asthma. And if so, we need to make sure to follow up. في وقت معين كانوا كاتبينه؟ Okay. Follow up during the early initial phase of treatment for neuropsychiatric side effects such as anxiety, irritability and aggressiveness, and sleep disturbances. Okay, pharmacological management. So هذه inhaled corticosteroids the most commonly used عندنا is budesonide and fluticasone propionate. Yeah, okay, ما في شيء مرة هنا. ايه اوكي حلو. بعد تعرفون الأنواع هنا. So في ال children هذا الجدول الثاني، لا in general اوكي. هذا لل inhaled corticosteroids وال long acting bronchodilator. هاي الخيارات اللي عندنا budesonide وفورماترول. budesonide formoterol هذا most commonly used صراحة أنا أستخدمه حتى. The brand name is Symbicort. The device type is an aerosol, and the device name is a turbuhaler. So the turbuhaler, here it is. It's very nice. Also, ممكن يكون عندنا budesonide formoterol بس at a higher dose. It's called the brand is Pulmoton. It's also aerosol. It's called an Alpenhaler. Alpenhaler can Alpenheimer. An Alpenhaler is something new, which is basically هذا هنا فيه زي الحبوب يدخلونها هنا، يقفلون هذا، يعني يسحبون الشريط اللي دخلوه عشان الحبوب تبقى هنا، بعدين يستنشقونه. أول ما يقفلون هذا يستنشقونه ويصير هاي الحبوب خلاص عطتهم الأيروسول. Alpenhaler. So you have a turbuhaler and an Alpenhaler. طيب, what about fluticasone propionate? This is taken with salmeterol. making sure you. This taking with salmeterol. الbrand name Seretide, probably سمعت فيها. This is also pretty common. And an Evohaler. It's an MDI, as in it's a dry powder axibagine. هذا هو. Also قد كنت أخذ هذا بس I switched to this. This is our Evohaler. And this is our discus. They're both fluticasone propionate and salmeterol. both من الشركة نفسها سيروتايب بس لهم واحد aerosol واحد dry powder واحد aerosol. Very purple. بس إضافة. طيب خلصنا الحين نشوف Saudi initiative strategies for asthma treatment in adolescents and adults. طيب اللي يكونون فوق خمس سنين وفوق هم plus الادولتس عندهم نفس التريتمنت strategies تقريبا. الفرق الوحيد طريقة الاسسمنت للأزمة. هذول قلنا عندهم الادولت عندهم ال ACT والchildren عندهم الchild ACT. طيب واللي 4 سنين وأقل هذول عندهم شيء مختلف تماما. Asthma treatment is based on the following 3 phases: initiation, adjustment of treatment, and maintenance. Initiation, adjustment, maintenance. زي كل دواء وزي كل مرض chronic. At each phase, the patient is recommended to have a clinical assessment that includes symptom assessment by the ACT, physiological measurement with the peak expiratory flow rate, review their current medications, their technique, risk for attacks, and response to treatment. Let's initiate treatment. بشرح لكم هاي الصورة وهذا نفس الشيء التفصيل اللي في الصورة. You can go through it وبنشوف الكيسز. طيب أهم شيء we need to know إنه we always have maintenance reliever. Reliever is always there. السب always there. الفنتولين always there. الحين بنركز حتى على maintenance. Initiate asthma treatment at the appropriate step based on the ACT score. The step 1 for ACT 20 or over. استخدم as needed. هذا بس as needed. ICS and formoterol as needed نحتاج reliever or SABA with ICS as needed. Sometimes بيكون نحتاج low dose of ICS. متى maintenance of daily low dose ICS is recommended for patients with symptoms more than twice a week, risk factors for acute exacerbations, kind of severe attack in the past year or prior admission, and evidence of fixed airway obstruction. Early introduction of ICS leads to greater improvement of FEV1. يعني متى؟ إذا كان ال ACT حقه 20 or more لكن إحنا عارفين إنه عنده risk factors مستقبلا ممكن يحتاج يصير step 2 يعني واضح فنعطيه ال ICS من الحين عشان نهيئه لstep 2. What about treatment initiation in step 2? Low dose inhaled corticosteroids and LABA with a reliever. And lastly, step 3, medium dose inhaled corticosteroids LABA with a reliever. شوف بس هنا في شيء extra. Okay. For patients with an ACT score of less than 16 presenting with early signs of asthma exacerbation, it's recommended to consider adding a short course of oral steroids. Not ICS, هذا inhaled corticosteroids, هذا oral steroids. إيش بالضبط? Oral prednisolone for 3 to 5 days. And those patients would need a close follow-up to adjust treatment as appropriate to achieve control. بعد هذا الكورس بعد هذا في step 3 we're going to follow up after 1 to 3 weeks, and if there's no improvement we're going to consider adjusting dose, assessing compliance and technique. If there is no improvement, refer to pulmonology. خلاص هذا خلص هنا شغل الفاميلي physician. Actually hold on wait لحظة شوف Okay, I hope ما جاف. طيب أعطيكم case and you have to guess. Hold on. Okay. So we have a 30-year-old who was initially on step 1 therapy, using as needed low dose inhaled corticosteroids and formoterol because his ACT was 22 points. At his follow up appointment 3 months later, his ACT score dropped to 17. Because the score is between 16 and 19, he's upgraded to step 2. What is his new regimen? Okay, 3, 2, 1. Oops. 3, 2, 1. His new regimen is a daily low dose of inhaled corticosteroids and LABA for maintenance and as needed relief using SABA or ICS for Moterol. طيب. So هذا يعتبر step 1 to step 2. طيب, a 45-year-old female initially on step 2 using daily low dose of ICS and LABA for maintenance and SABA for relief. Her initial ACT score was 18. After 6 months of the regimen, her follow-up ACT score improved to 23. Since she achieved sustained good control, 20 points or more, she is downgraded to step 1. What is her treatment now? 3, 2, 1. Her treatment is to stop the daily maintenance and switch to only low-dose ICS for Moterol on an as-needed basis. So this is step 2 to step 1. What about this one? A 20-year-old... قاعدة أشرح فيديو. A 20-year-old male was started on step 1 therapy using only as-needed ICS for Moterol due to an initial ACT score of 21 points. He presents urgently with increasing symptoms, and his ACT score is measured at 14 points. Poor control. Because the score is less than 16, the treatment is rapidly downgraded to step 3. What? Rapidly upgraded to step 3. طيب. What is the treatment now? What is the new regimen? So step 1 to step 3, the regimen is starting daily medium dose ICS and LABA for maintenance and using a reliever, in this case ICS or formoterol, ممكن SABA, and adding a short course of oral steroids for oral prednisolone for 3 to 5 days to quickly manage the acute deterioration. إذا عرفتوا هذا, this is very good. وأهم شيء هذه طبعا كاتبتها تالا يعطيها العافية, مو من السلايدز الأصلية. إذا تحبون تشوفوا أشياء زيادة تشوفون التفريغ في مدركال. هذا شرح زيادة لهم. Okay. طيب, when exactly should we step up, نروح فوق, نروح تحت, if asthma control is not achieved within 2 to 6 weeks? هذا رقم 2 to 6 weeks despite adequate technique and adherence. قلنا احنا دائما لازم نتأكد إذا patient uncontrolled, ناخذ history ونشوف. أهم شيء نشوف adherence technique قبل ما نبدأ نغير في الدوس. طيب, when do we step down? Step up احنا نبغى يعني it's getting so bad بسرعة 2 to 6 weeks كفي. Step down, are we sure this patient's good? So we need to make sure that the patient maintains good control for at least 3 months. In clinical practice, the severity can be okay هذا زيادة. When do we say the asthma is controlled? زي ما قلنا قبل, في تفاصيل كثير بس احنا يهمنا ال ACT. More than or equal to 20, 16 to 19, less than 16. and clinical practice, severity can be retrospectively assessed. So مثلا احنا if we're not sure بالضبط إذا هو يعني الصورة مو مرة واضحة based on the history، نشوف الأزمة حقه. إذا ضبط مع step 1 فنقول كان عنده mild asthma. إذا كان also ضبط على step 2 كان عنده mild asthma. لو كان controlled by step 3 moderate asthma. والsevere هذا اللي لا يعني family medicine but it's controlled by step 4 or step 5. Now we have to maintain asthma control. بمشي على هذا قبل. طيب أهم شيء قلنا إحنا إذا patient well controlled متى we step down 3 months. طيب إحنا هل نسحب على المريض نخليه for 3 months وما نشوفه؟ لا. We need to reassess the patient every 1 to 3 months. طيب patients all good وخلاص حتى يعني نبغى الحين we're gonna wean them off of the treatment. So when can we can't completely discontinue the treatment or it's going to cause asthma control deterioration. نحتاج نقلل ting 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 ting. لو كان with step 1, so meaning the patient only takes inhaled corticosteroids as needed, but takes a reliever as needed, we're going to reduce the inhaled corticosteroid dose gradually every 3 to 6 months until we identify the lowest effective dose and keep it as a once daily single dose. شيء كذا يصير خلاص كان هو ياخذ as needed، لا خلاص احنا ما نبغى ياخذ as needed، نبغى ناخذه كل يوم عشان هو he doesn't need it now، بس ناخذه كل يوم to prevent a relapse, to prevent a future attack. So we're going to reduce it gradually over every 3 to 6 months. If the patient is at step 2 or step 3 معناته ياخذ ICS and LABA. هنا شيء مهم. طب إيش نوقف أول ICS ولا اللابا؟ مو هم دواء واحد ونوقفهم كلهم مرة واحدة؟ No. لازم نوقف واحد منهم. Don't discontinue LABA first. لا أوريك شغلك لو وقفت اللابا. لا. طيب. Do not discontinue LABA first. It will cause rapid deterioration of the ACT. So first we gradually discontinue ICS بهذه الطريقة لما نلاقي lowest effective dose. بعدين we can discontinue LABA بكبره. و if we discontinue LABA بكبره خلاص صار بس عندنا ICS نمشي على ICS identify lowest effective dose بعدين keep it once daily. Pretty good. يلا نشوف هنا. اختصرت لكم اللي موجود هنا. هذا أول شيء ال treatment in general. Okay, you can go over it. نفس ما قلنا mild and moderate و severe. Maintaining asthma control. Recommend to assess patient every 1 to 3 months. Stepwise approach is not meant to be compartmental. It's rather a continuum of care based on patient engagement and close monitoring of the disease. معناته it needs to be dynamic, it needs to be flexible. لو تغير البيشنت عادي ما نقول لا والله هو لسه نشوف إنه عنده severe كذا خلاص. و based on results نمشي على الالجوريثم حقنا. كلام كثير يتكرر عشان كذا سلايدز كثيرة. أي هذه الأشياء خلاص شرحتها. وهذا اللي قلت لكم عنها ال steps in general عشان نعرفوا what are the steps. طيب الحين ندخل في ال asthma in children. Asthma in children أول شيء what are findings suggestive to diagnose asthma in children؟ الأشياء الواضحة الهيستوري اللي قلنا coughing, reduced activity, impaired on life activities, family history of atopy and asthma in first degree relatives. طب atopy زي إيش؟ eczema, allergies, food sensitization, wheezing زي ما وصفنا, breath sounds, prolonged expiratory phase. وعندنا therapeutic trial. إيش therapeutic trial؟ هذا إذا كنا شاكين إن البيشنت عنده asthma، نعطيه short trial of inhaled corticosteroids، نعطيه for 6 weeks، بعدين نوقفه بعد 6 weeks ونشوف الريسبونس حقه. إذا ما كان في improvement في السيمتومز اللي كان يشتكي عليها فمعناته احتمال إنه ما عنده أزمة وخلاص ما يحتاج نشوف موضوع الأزمة. لكن إذا أول ما وقفنا السيمتومز رجعت، سواء على طول يوم وقفنا أو بعد فترة رجعت، we reintroduce inhaled corticosteroids and adjust dose accordingly. معناته على طول نقول diagnosis، نعطيه inhaled corticosteroids. نسوي spirometry، بس هذا typically in children that are over 5، مو age range اللي هم 4 and less. Chest x-ray ممكن يكون in infants just to rule out any other causes, birth defects. Tests for hypersensitivity, skin testing, and IgE blood testing, and eosinophil count. طيب هذه الكرايتيريا، actually these are written, let's see a screenshot. هذه الكرايتيريا to diagnose asthma predictive index in children. So we have a history of 4 or more wheezing episodes before the age of 3 years, which is diagnosed by at least one physician. We need at least 1 major criteria and 2 minor criteria. So parental history of asthma, skin test is positive, and eczema. هذا من major criteria. Minor criteria الأشياء اللي أحيانا تجي أحيانا مو شرط تكون موجودة: eosinophilia, wheezing unrelated to colds, and allergic sensitization to specifically milk, eggs, or peanuts, the most common ones. نحتاج 1 من هنا و2 من هنا. طيب شخصنا وقلنا يس عنده أزمة. طيب الحين إيش الجهاز نستخدمه لهم؟ إذا كان بيبي less than 4 صغير، نعطيه meter dose inhaler with a spacer and face mask. كذا شكله، ما هو زي الماوث بيس اللي يحتاج إنه يدخل فم ويكون في coordination، لا. alternative نعطيه nebulizer. إيش الفرق بينهم؟ هذا النبيلايزر الجهاز that turns liquid medication into inhalable mist، وهذا MDI الجهاز العادي اللي نعرفه. إذا ما كان يعرف MDI وكان صعب عليه نعطيه النبيلايزر عادي. طيب 4 to 6 خلاص كبير بيدخل صف أول، we can use a spacer with a mouthpiece، خلاص يعرف كيف. إذا ما يعرف nebulizer with a mouthpiece. more than 6 years عندنا خيارات كثير، خلاص هو ذكي الحين: dry powder inhaled, MDI with spacer or mouthpiece. spacer هنا الهدف منه مو عشان يعني اللنج صغيرة زي اللي قبل، هنا مو زي airways صغيرة هنا because it doesn't require coordination of breath with the released medication. يعني حتى تكون نضغط الزبع على طول. هنا إذا الطفل كان يعني واجه صعوبة في هذا الشيء نعطيه السبيسر. وإذا كان يبدأ no alternative nebulizer with mouthpiece لأنه خلاص you're big. طيب هنا قلنا في شيء اسمه ال children CACT. هذا for children أنا كنت أقول 5 or more to 12 4 to 12 4 to 12. أو نقدر نستخدم other test. طب إذا في طفل أصغر نستخدم track score. So هذه 2 scores يتخلينا نعرف إذا هو controlled or not controlled. For CACT, controlled if it is 19 or more, uncontrolled if it is less than 19. For track, it is controlled if it is more than 80 or more, uncontrolled if it is less than 80. أحس حاجة ممكن تساعد إن 9 و8 و9 و18 دايما مع بعض، بس just switch them around. نبدل 8 مع 9 19 هذا 8 switch 8 CACT 19 والtrack 80 طب والACT 20 19 to 16 16. Asthma treatment in children is شوي غير بس مو مرة. So we start at step 1 when asthma is controlled. So CACT is 20 or more. Oh, هنا يمكن 19 or more. The recommended option is ICS whenever SABA is needed. هنا we want to avoid using SABA ما هو زين الأطفال. فبدالها ونعتمد mainly على inhaled corticosteroids. بس if a children has intermittent viral induced wheeze لا هنا لازم ندخل السابة في الموضوع. سابة as needed basis. طيب what about step 2 if it is uncontrolled or partially controlled نفس الشيء احنا عندنا يا controlled يا uncontrolled. Partially controlled يعتبر uncontrolled. The recommended option okay, I'm just a bit confused. هنا يحطون 19 وهنا يحطون 20 بس maybe يعني في اختلاف بسيط على الموضوع. The recommended option is regular low-dose ICS for a child with more symptoms. كان يعني عنده more symptoms نقول step 2 ونعطي regular low-dose ICS على عكس هذا اللي كان as needed. نقدر نستخدم the leukotriene receptor antagonist as an alternative even though it is less effective. طيب إذا كان الأزمة إذا كان الأزمة uncontrolled لكن with more severe symptoms قاتب هذا اللي كان يعني عادي symptoms بس كثيرة. The recommended option is low dose ICS with LABA, either MART or a different non-formoterol LABA. And we also need SABA as a reliever. Okay, هنا قلنا no SABA, no SABA. لكن إذا كان عنده viral induced wheeze هنا regular low dose ICS. هنا we introduce SABA. Other options for escalating to daily moderate dose ICS, monotherapy, or adding a leukotriene receptor antagonist to the low dose ICS. أهم شيء هنا لو شفتوا في 3 we want to keep a low dose على عكس حق الادults. هذا 5 to 12 similar حق الادults لكن نبغى low dose all the time. طيب أشوف وين متى نسوي step down. طيب إذا نبغى نسوي step down لاحظنا تحسن في الأعراض تحسن في الأعراض and we want to step down the patient uses ICS dose we're going to reduce it by 25 to 50% every 3 months until the lowest effective dose is achieved specifically بهذه المدة. For patient in step 3 زي ما قلنا للadults reduce ICS before LABA. فهنا كان reduce ICS dose gradually every 3 to 6 months. هنا every 3 months أطفال شعب صغار يعني 3 months تفرق معاهم by 25 to 50% specifically. طيب what about in children aged less than 5 قلنا يسخنون التراك سكور قلنا إما 80 or more. قلنا إذا هو لخبط في حاجة, my bad. More than 80 control, 80 and less uncontrolled. طيب إذا كان less than 80, يعني إذا كان قصدي more than 80 يعني controlled, recommended is as needed SABA for a child with minimum symptoms. هذا عكس ال children اللي from 5 to 12. هذوليك لا, هذيك ما ياخذون SABA. There's SABA, and also إذا كان intermittent viral induced wheeze, also SABA. طيب إذا كان uncontrolled or partially controlled and the mild symptoms, we start on a regular low dose ICS for a child with more symptoms, طيب mild symptoms. Alternatively نستخدم ال leukotriene receptor antagonists نفس أول. A short course of low-dose inhaled corticosteroids at the start of an upper respiratory tract infection is another alternative option for episodic exacerbation. بس يعني نفس التريتمنت في النهاية. Low-dose inhaled corticosteroids. طيب هنا اللي يفرق. إذا كان الطفل الحين عنده severe symptoms uncontrolled, إيش نسوي؟ نعطي المارت, نعطي الفورمادرول? No. We still use ICS, بس هنا we use a double low dose for a child with more persistent symptoms. هذا هنا ملخص للمانجمنت, وهو نفس الشيء. If the patient is on ICS as monotherapy, the dose of ICS may be reduced by 25 to 50% every 3 months to the lowest possible dose that is required to maintain control. نفس الchildren. Okay. Now عندنا الأكيوت أزمة. بخليه إن شاء الله في فيديو ثاني عشان يكون أسرع ولسه شوية يبغاله.